Good morning, everyone. Today we will be dealing with chronic rhinosinusitis. This is again the same counterpart of the acute rhinosinusitis. Most of the clinical features or the etiology would be remaining the same, but then the diagnostic criteria would change. Why? Because the treatment for acute rhinosinusitis and chronic rhinosinusitis is completely different, and depending on various other factors, whether if at all to do a surgery or not, is what is going to be dealt with. For our practical purposes, we'll be dealing only with chronic rhinosinusitis. In reality, we'll be having chronic rhinosinusitis with polyposis, without polyposis. But that is all what do we say, postgraduate level thing. So that's why I will not be bothering you about the polyps part for you. Right now, we will just deal with chronic rhinosinusitis. With respect to my teachers, let us begin our today's class. For everything, we need to have a diagnostic set criteria. Unless we meet these criteria, we cannot say that this person is having chronic rhinosinusitis. Apart from this, the diagnosis, we also have something what is called as a SNOT 22. That is a scoring system based on the patient's feeling or the patient's way of appreciating what the changes he's feeling. That will determine whether or not he is actually chronic rhinosinusitis. So here, by definition, we should require 12 weeks or more of one of two or more of the following. That is, either there should be minimum two of criteria, that is there should be a mucous discharge or obstruction, facial pressure or fullness or headache, or decreased sense of smell. Well, decreased sense of smell is only seen in cases of polyposis, very rarely other diseases. So essentially, the moment we have anyone who is saying that there is a decreased sense of smell, essentially we are dealing with polypoidal changes. Until and otherwise, it's a rule of thumb that smell will not decrease. But apart from these two criteria, there should also be documentation. See, it's not just symptoms, it's also sign. That is, there should be a purulent discharge from the middle meatus or in the anterior ethmoidal region. There should be the polyps in the middle meatus, or there should be a CT scan imaging. Please remember, the criteria for doing a CT scan also changes, because you cannot have a common cold and do a CT scan on the first day or second day of common cold. It will invariably be showing as filled up with sinusitis. So there has to be an adequate medical treatment, only then we can ask for a CT scan, unless in cases of emergency. So please try and understand, everything has got a exception. We are supposed to deal with a properly medically treated disease which is not amenable to the line of treatment. Only then we can have a radiological investigation, because again the investigation itself is costly, somewhere around 3 to 4,000 at any given lab, which is not what for maybe an acute disease which is really unwarranted for, or for an untreated disease which again compromises the professionalism. So multiple issues are there, plus this will be what is a very important question maybe for your 4 marks or in your viva voce. Then what exactly is this? This is a tussle going on between the normal epithelium, that is the ciliated columnar epithelium, and a host of other factors. You can say something like the Thanos versus the rest of the superheroes. But in reality, Thanos is alone, but here we have the epithelium which is alone. Why do I say this? Because an intact epithelium is the only thing which is preventing any sinus infection. Otherwise, say for every one of us in the world, there are enough bacteria, enough viruses, and at least 2 to 3 million fungal spores for every person on this earth. That means everyone should be affected. Why are we not affected? Because the epithelium is intact. The moment we have an epithelium which is intact, even though there is a fungal spore, even though there is a virus, it will be washed away by the ciliary mechanism. That is what, whenever we want to speak and all of a sudden we stop and we swallow whatever is coming in the postnasal drip, that is what is the ciliary mechanism at work, which is pushing whatever the secretions from the sinuses into the oropharynx. The moment it comes into the oropharynx, it is our choice or habit what whether we swallow it or we spit it out. The organisms again are the regular routine microorganisms, Staph aureus. At times even gram-negative organisms can also be there. Fungal elements will be more now. Fungal rhinosinusitis itself is a as good as a 10 marks question for PG level. So I'm not going to confuse you between them. So fungus is going to be in another thing. Apart from all this, presence or absence of allergy will change the epithelium. The moment epithelium is there, is losing its integrity or is subjected to signs of inflammation, the organisms what were upper easily moving away into the oropharynx would become stasis and lead to an infection. Again, external factors like pollution, smoking, everything will affect how the epithelium will behave. That's why this is a tussle between the normal epithelium, intact epithelium, and a host of other things which are going to take care of the sinus infection. What do we have? We have congenital causes, which itself, that is cystic fibrosis, which prevent the secretions from being washed up, cartilaginous syndrome, wherein the cilia will not be in a position to move a beat about, or primary ciliary dyskinesia. So every single thing which hinders the ciliary movement will contribute to the stasis of the mucous glands or the secretions. The moment there is a stasis, we expect a, a bacterial growth or a viral growth. This would in turn be secondarily affected by bacteria definitely and lead to the sinus infection. Apart from this, normal variations like uncinate. Uncinate is a bone which is parallel to the lamina papyracea, that is the orbital wall. Here, at times, this is not always straight. At times, it is laterally bent. At times, it is medially bent. That is where it is called as a double turbinate. So any anomaly of uncinate would in turn cause either more of a make the person more susceptible for chronic rhinosinusitis, presence of concabulosa, that is pneumatized middle turbinate. Normally turbinates are bony curvatures, but at times this bony curvature will be filled up with air. In case of a middle turbinate, that's the only thing which is normally pneumatized. This is called as concabulosa. Superior turbinate can also be pneumatized. It is very rare, but it is a possibility. Inferior turbinate never ever can be pneumatized because it's a separate bone. Superior and the middle turbinates are the part of ethmoid complex. Please remember this. And presence of deviated nasal septum because of its various anomalies. If you remember in the last previous classes I have told you, either because of the C shape, S shaped or the spurs, there may be a impingement of the mucosa which will lead to inflammation. Inflammation in turn will lead to blockage of the sinus drainage, which will lead to chronic rhinosinusitis. Again, inflammation. Inflammation is because of multiple things, as in a person who is having frank allergy, or any person who is atopic, or a person who is sensitive to aspirin. Almost 10 to 20% of the people, especially elderly age group, who take aspirin for their cardiovascular diseases, they develop some sort of sensitivity, which will in turn make them susceptible for chronic rhinosinusitis, more so cause polyposis. And people with asthma are have approximately a 30% chance of developing chronic rhinosinusitis. At the same time, people with chronic rhinosinusitis have a 30% chance of developing asthma. It works both the ways. And again, there is no infection. Please remember, these are all inflammatory changes. And sinusitis per se is an inflammatory disease. It's not an infective disease. Infection occurs secondary to inflammation. Why? Because I told you the bacterial flora, the surrounding structures are really bad in case of oral cavity and nasal cavity. Infection, what can cause? There is something what is called as a biofilm. What exactly happens here? In this, because this may be a 2 marks question also. Biofilm is whenever, if at all you remember, uh, you have observed in the house or in the kitchen or in the bathroom, there is a very slimy layer if at all there is constant use of water and it has not been cleaned. That layer will will cause slippery nature to the tile, or will create a sort of a greasy nature. Now, in the sinus wall, depending on the mucosal stasis, the bacteria will generate a scaffolding. This scaffolding houses the bacterial inflammatory triggers, which will be impregnable to antibiotics. Antibiotics work when the bacteria are in contact with the antibiotic. Supposing if there is a biofilm or a scaffolding which will prevent the antibiotic from coming in contact with the bacteria, how will you take out the infection? So please remember, biofilm is one of the recent things which we have understood. Even when I did my PG, the concept of biofilm was not there. But now, last 5 6 years, biofilm itself is a huge thing. Fungal infections per se will not be a cause for chronic rhinosinusitis unless they are in a immunocompromised host or because of some other factor which will lead to a fungal infection. Entirely different section, that's why I'm not making you detail about it. Dental, if you remember, maxillary, molar, second molar, first molar at times will not have any bony gap. That is, there will not be any bone between the roots of the maxilla or maxillary tooth, or molar tooth, and the maxillary sinus. So if at all that develops an infection, that will be leading to a maxillary sinus. And by mistake, if the dental surgeon, without thinking of sinusitis, decides to take away the tooth, this will lead to oroantral fistula, which is really a bad disease. The treatment is really a prolonged treatment, and the suffering is not worth it. Immunocompromised host, as in HIV, because the diseases which contribute to this are completely different, and uh, I don't really want you to go into this immunocompromised host for now. Again, the clinical features, what do? They will cause block. Please remember, more or less same features as in acute rhinosinusitis. What changes is the duration. What changes is the diagnostic criteria. What changes is the medical treatment, or we are going for surgical treatment. The block can be unilateral, can be bilateral. Block can be alternating from one nostril to the other nostril. Again, block has to be differentiated from block secondary to the septal deviation. Discharge. Usually, discharge is mucopurulent to purulent in nature, a greenish or yellow colored. Very rarely dark brown or any greenish brown material which is very sticky, which will be called as a mucin, is seen in cases of fungal infection, and all this with or without the presence of polyposis. Now, why should there be a facial discomfort when there is a sinuses which is filled with pus? Because the sinuses are supposed to be filled with air. They make the skull light. Supposing anything which is filled up instead of air with fluid, and that fluid is causing infection leading to inflammation, you will have facial discomfort. And hyposmia is usually because of the edema around the nerve endings. Once we clear the chronic rhinosinusitis, hyposmia or decreased sense of smell will also go off. But please remember, hyposmia is a feature of ethmoidal polyposis. Apart from this, what will this do? Remember, all throughout the cilia are still working. If the maxillary cilia are blocked or they are not in a position to beat, the area around the uncinate will be having the cilia which will be trying to push the secretions more posteriorly. The secretions, because they are in a closed cavity, they will be bursting out, oozing out. The moment they ooze out, they have to be trickling into the oropharynx. So what do? They will cause a irritation of the throat, posterior pharyngeal wall, which will lead to hawking. Hawking in turn will cause a cough. Sore throat, because the posterior pharyngeal wall, once it starts getting inflamed, the whole posterior pharyngeal wall all the way down till the inferior constrictors are affected. Apart from this, we have malaise, that is generalized body pains with or without fever, and there will be a change in the voice. Why? Because up where we have what do we see? Functions of sinuses. We don't know whether what the function of sinus is. We assume they are to cause light weight to the skull. We assume they are resonating chambers, but we don't know. We don't even know whether they are vestigial organs. We don't know whether they are there for a purpose or they are not there for a purpose. We just think that they are there because we may require a resonance to our voice. So that's why whenever we are having sinusitis, people on phone, you would be recognizing each other. अरे आवाज बदला है. Yes, there will be a change in the voice. Now this what is called as rhinolalia clausia. There is something else which is called as rhinolalia aperta. Aperta is seen in cases of cleft palate and other things. So how do we investigate? There's something what is called as a diagnostic nasal endoscopy, wherein we visualize the interior of the nasal cavity using an endoscope, which is normally a 4 millimeter endoscope. And after we give topical anesthesia and decongestion, decongestion is theoretically by cocaine, but what we normally routinely do is we use oxymetazoline or xylometazoline with or without adrenaline. What this will do is it will cause vasoconstriction of the turbinate and the mucosal layer of the turbinates. So the moment there is a vasoconstriction, the space is visualized and we can see the finer details. This will be shown in your practical classes, and at the same time will be in a position to identify whether you'll be able to have a culture and sensitivity or not. Apart from this, what do we require? We require a CT scan to confirm whether there is a sinusitis or not. Practically, for all practical purposes, we do not routinely advise a X-ray PNS. Previously, X-ray was the only method of treatment, I mean, a method of radiological examination method. But right now, imaging of choice is CT scan. Why not MRI? MRI does not pick up fine bony details. As a matter of fact, bone is not at all seen in MRI. So that will handicap us from identifying the major structures, because we are all in a bony cavity. We are not bothered about the soft tissue because most of the times it is fluid or purulent discharge. Very rarely will be coming across malignancy. In that case, yes, definitely MRI will also be required. And always allergy testing, as in allergy itself is a completely different topic, but the minimum what we require is a serum IgE levels. Why? Because If the allergy is the cause for chronic rhinosinusitis, no matter what good surgery you do, we will always be required to take care of medicines only. Surgery, even if you do for the first time, the problem will come back. Why? Because you have forgotten to do a allergy testing. So what do we have? One, medical line of treatment, wherein just like in case of our acute rhinosinusitis, we need to give antibiotics. I told you that this is an inflammatory disease, not an infective disease. Then why an antibiotic? Antibiotics are required for secondary infection. Majority of the times, by the time the patient presents to us, he will always be having a mucosal stasis which will be infected. Purulent discharge will always be seen. The preferred antibiotics are penicillin groups followed by cephalosporins. Very rarely azithromycin or clarithromycin will be effective. Apart from that, other groups are very rarely used. Everything again depends on culture and sensitivity. Corticosteroids, either in the form of systemic tablets, intravenous or oral form, or intranasal spray, are used. They are usually used in cases of polyposis. We have huge polyps which fill up the nasal cavity on both sides, and all of a sudden we give corticosteroids. After 1 or 2 weeks, you will be surprised. You will be not seeing the polyps at all. That effective are the corticosteroids. But the use is to be judiciously taken care of. Apart from this, irrigation of the sinuses is very important. That is steam inhalation, and at times we also use something what is called as a jalaneti, wherein water is pumped from one nostril into the other, wherein you'll be having a fluid which is coming out of the sinuses. But for all practical purposes, because sinuses are air-filled cavities, we require steam, more important than irrigation. Saline sprays are also available. Then, what do we have for surgery? For each sinuses, there are different set of surgeries. And surgeries previously were open surgeries, but now they are closed surgeries are preferred. The most important would be an antral lavage. This is done by a Lichwitz trocar and cannula. Here, the this is for maxillary sinus, and we pierce through the inferior meatus at the level of genu, and the direction is towards the same side ear. This has got again, and it is irrigated by using warm saline with a Higginson's balloon pump. Now Higginson's syringe. Now previously, say 20 years back, every ENT OPD used to be doing minimum of 20 to 30 antral lavages, irrespective whether the maxillary sinus was affected or not. And believe me, nowadays no one, no one does antral lavage. Intranasal antrostomy is a second thing, wherein which was done with a Tilly's harpoon and a antral burr, which would be inserted as a dragger in the inferior meatus and try to open up a large opening. But please remember, sinuses do not drain from large openings, they open or drain from their natural ostium. The moment the natural ostium is opened, only then the large opening will be helpful. Otherwise, you'll be having a large opening and a natural ostium which will not be working. So, third procedure, again, this is also for maxillary antrum. The third surgery is the most common Cadwell-Luck operation, which will be a 2 marks to 4 marks question again for you people. Though not done, it still has got a role in cases of, say, a foreign body in the maxillary antrum or chronic maxillary sinusitis, which is not malleable, treatable with the endoscopic sinus surgeries, or in cases of mucoceles, or in cases of antrochoanal polyp wherein we are not able to reach the stalk. So when this usually done under general anesthesia for the sake of comfort of the patient, we give a sublabial incision 3 millimeters above the uh, labial line into the mucosa and open a separate periosteal flap. We don't go directly into the periosteum. Why? Because it will create a fistula from the maxillary ostium into the oral cavity just below the lip. So there we go through the canine fossa. Why? Because canine fossa is the part which has got the thinnest bone in the anterior wall of the maxilla, and we gradually open this opening approximately 2 into 1 centimeter wide. But at the same time, we are supposed to take care of the inferior maxillary nerve, alveolar nerve, which is superior end, and inferiorly the root of the tooth, which may come in contact, and we may lose the teeth also. So these are the two common surgeries. You will have to go through the steps again in a proper textbook way. Intranasal ethmoidectomy, transantral ethmoidectomy was previously done. This is what is called as a Jansen's procedure, but now it is not done. Lynch-Howard and frontal trephination osteoplastic flap were done for opening the frontal and the ethmoid complex. That is, Lynch-Howard incision was for the frontoethmoidal ethmoidectomy. Frontal trephination was only for frontal sinus, and osteoplastic flap, which is a very morbid procedure requiring too much of skill on the part of surgeon and suffering on the part of the patient. Now all this has been revolutionized by something what is called as a functional endoscopic sinus surgery. Why do we call it as a functional endoscopic sinus surgery? Please remember, the sinus mucosa or the nasal mucosa is a very important thing. That is, having the cilia beating around is the most important thing we could ever have in our body, because the moment it is traumatized because of surgery or anything, the cilia will not be remaining the same, they become fibrosed. So the epithelium is only a squamous epithelium, or epithelium may be replaced by a fibrous tissue. This is what will happen in case of intranasal antrostomy or a simple antral lavage. So, in order to maintain the mucosal integrity, that is, we are maintaining the function, and because we are using the endoscope and we are operating on the sinus, this is what is called as a functional endoscopic sinus surgery. This again is a very important viva voce question. The anesthesia is either general anesthesia or local anesthesia, but for all practical purposes, please say it is only general anesthesia, and the steps involved are for the maxillary process, the maxillary sinus, it's uncinectomy followed by middle meatal antrostomy. That is, we have to remove the uncinate and open the maxillary ostium. Please remember the maxillary ostium and the opening is completely posterior to the perpendicular horizontal part of the uncinate process. So unless that natural ostium is opened, we will not be having a functional surgery antrostomy, followed by ethmoidectomy, which is anterior ethmoidectomy and posterior ethmoidectomy. Anterior ethmoidectomy is identifiable by the bulla ethmoidalis, which is the largest structure seen immediately after the uncinate process, and once we cross that, the posterior border is the ground lamella. We need to go through the ground lamella to reach the posterior ethmoids. This is a very important point. At the same time, at the level of ethmoids, laterally we have the lamina papyracea, that is the orbital wall. Medially, the vertical part of the middle turbinate. If we disturb that, there will be a fracture in the roof which will give rise to CSF rhinorrhea. So we are working between just 1.5 centimeters, making sure you are not piercing either laterally or medially or superiorly. The direction is in posterior and inferior only. This will not be understood by you. You will have to see the surgeries. There have been instances wherein people have gone into the orbit, which is in a way less dangerous. They have gone into the cranium and removed part of the frontal lobe also. So that how dangerous this operation is. Next, followed by sphenoid ostium opening, wherein we go through the sphenoethmoidal recess. And last is what is the frontal sinus opening. That is, we widen the frontal, we uncap. There is a very clear word, uncapping of the frontal sinus. Now, this is what is functional endoscopic sinus surgery. Apart from this, we have something the more recent is balloon sinuplasty. Why? Because this is based again on the principle that the sinuses are fine paper thin like bones. So in order to open a small opening, why do we need to do a large surgery? So this works on the principle that we thread a guide wire into the sinus opening and pass a balloon, something like in angioplasty, so that this and pull it out. This way the sinus is widened. This is mostly used in case of frontal sinus and in case of maxillary sinus. This requires a bit of skill, for which not everyone, the equipment is also very costly. Each balloon sinuplasty would be, for one patient, 40,000 equipment charge itself, which is bit too steep for anything. So this is what is about chronic rhinosinusitis. Thank you.